Hello, everyone. My name is Jana Schade from Switzerland. I'm here together with my colleague Jan Silva from Brazil and Dr. Riew. So today I want to welcome you to another session of Academic Talks, an initiative of the AO Spine Youth Club in collaboration with the AO Spine Knowledge Forums. And today we're with the Degenerative Knowledge Forum. This series is designed to deliver focused, high-level academic discussions on topics that directly impact daily clinical practice.
Uh, Today's topic addresses a common and often controversial question on cervical spine surgery. What are the most reliable criteria to define fusion after ACDF? In practical terms, how can we confidently distinguish a solid fusion from a pseudoarthrosis, and how should this assessment guide follow-up imaging, clinical decision-making, indications for revision surgery?
It is our true honor to welcome Dr. Daniel Riew as our guest speaker today. Dr. Riew is an internationally recognized leader in cervical spine surgery. He's a professor of orthopedic surgery in the Department of Neurologic Surgery at Columbia University Medical College, and he's the chief of cervical spine surgery and a co-director of the Spine Fellowship program in the Department of Orthopedic Surgery at Columbia. And he's widely known for his lifelong focus on cervical spine pathologies, his extensive surgical experience, and his major contributions to clinical research in this field.
Yeah. Dr. Riew is a past president of Cervical Spine Research Society and has played a pivotal role in shaping contemporary concepts in cervical spine decision-making, outcomes assessment, and interpretation of postoperative imaging. His perspective on fusion criteria after ACDF is grounded not only in the literature, but also in decades of real-world surgical experience.
So thank you for joining us today, and it is our great pleasure to welcome Dr. Daniel Riew for this academic talk on fusion criteria after ACDF. So we will see now a presentation from him first, and then we will have some questions.
All right. Well, thank you very much. I really appreciate that kind introduction and allowing me to give my presentation today. And first, let me give my disclosures. I do get royalties on some products and have purchased some stocks in various companies. So we, as surgeons, never really want to hear when a patient of ours that we've operated on is having recurrent symptoms or they're not doing well after surgery, because we want all our patients to be happy, because when they're happy, we're happy. And when they're not happy, we're not happy. And that just is a sign of being a good doctor, because you should feel what your patient feels. And so after an ACDF, there are patients who can come back and say that they have constant severe pain. And often the surgeon may say, I don't see anything wrong on your MRI, on the CAT scan, or an X-ray. So imagine if you were the patient, you had just had an ACDF, you went back to the surgeon and you said, my symptoms went away for a while, but then they've come back and they're just as bad as they ever were. And the surgeon says, I looked at your MRI, we got a repeat CAT scan, we got an X-rays, and everything looks good. What would you as a patient do? Would you say, it's in my head, the surgeon must be right, and there couldn't be anything wrong if the surgeon says that there is nothing wrong, and you would just settle with that? Or would you say, you know what, I know there's something wrong. I'm hurting, and I really shouldn't be hurting after an operation that was supposed to fix this pain. And would you go and get another opinion? Well, 99% of us would not sit there and say, the surgeon must be right, it's in my head. We would get another opinion. Is that correct? Yeah, of course. So then you have to ask yourself, how do you actually diagnose a pseudoarthrosis after an ACDF? Do you look at bridging bone? Do you look at bridging bone along with flexion extension views? Or do you look at bridging bone, flexion extension views, and maybe even a CAT scan? And some people might get other studies like a SPECT CT or things like that. But when you look at static images, you look at this and you say, okay, at 1 year post-op, this patient looks like they still have clefts here. This is an obvious pseudoarthrosis. And when you look at 2 years post-op and you say, okay, that bone looks like it's very well bridging, that must be a solid fusion. So static images can give you some of that information about whether you're solidly fused or not. But when you take a look at something like this, it's much harder to tell. So this patient had an ACDF done at an outside institution in another state. And everything went well, and she did well for a while. And this is a physician, and she said for the first 6 months I felt okay, but around 6 months she began having recurrent symptoms. So the surgeon gets flexion extension views, looks at them, and says, "There's no motion there. You're solidly fused." And then they get an MRI. And on the MRI, the surgeon says, there's no stenosis. Everything looks good. I'm not sure why you're still having arm pain, but it can't be coming from the neck because at every single level, the foramina are wide open, the spinal cord is well decompressed. And they get a CT, and the radiologist and the surgeon, they look at it and they say, there's bridging bone inside of that cage and over here and over here and over here. And I don't see anything wrong. So the doctor goes and gets a second opinion from another surgeon. And the surgeon looks at this and says, "Yeah, I agree with your surgeon. You're solidly fused. There's nothing wrong there. Your MRI shows everything wide open. So we don't really know why you're having the symptoms, but it's not coming from the cervical spine, or you just have irreversible nerve damage." But let's really drill down and take a look at these flexion extension views. And if you take a look and you actually measure this, you see that between flexion and extension, if you pick the exact same spots, there's 3 millimeters plus, it's actually about 3.9 millimeters of interspinous process motion at the C5-6 level. And at this level, you have over 2 millimeters of interspinous process motion. Now, when you take a look at this, you can, if you look carefully, see that there are subtle signs that there's motion there, even without measuring. But clearly, when you measure these distances, you go, yeah, there's definitely a lot of motion there. And then if you really magnify the image, you see that there are other signs that things are moving. So on extension, the gap between the cage and the bone gets bigger than when they're flexing their neck forward. And the gap up here gets bigger on extension. Same thing here, that when you flex down, that gap narrows, and on extension, that gap increases. So just by looking at the flexion extension, but much more carefully, you can tell that there's a non-union there. So this patient, we fixed posteriorly. In fact, when I told her she had a non-union, just go back to the original surgeon and say there was a non-union. She went back to the original surgeon and told him, Dr. Riew says that I haven't healed, and you just need to fix me in the back with a couple of screws. He said, "Nope, you're healed. There's nothing wrong with you." And so I said, "Okay, come on back. We'll fix you." We fixed her. Pain went away and all the symptoms resolved. And the patient basically said, "Can I sue my original surgeon? Because he sat on me for a couple of years when I was complaining about pain and said there was nothing wrong. Even when you pointed out that there was something wrong, he still would deny it and not fix me because he thought that I was crazy and that it was all in my head." Well, I hear this almost on a monthly basis. Patients seek me out if their first operation didn't go well. And when I look at it and I say, "You have a non-union," they say, "I don't understand why the first surgeon couldn't figure this out." So I would tell you as a surgeon, if you can figure out something that other surgeons have not been able to figure out, patients will beat a path to your door because they're looking for answers if they've had the first operation and they're not any better. So we published this study on how to tell with plain radiographs whether you're solidly fused or not. You must get, and we looked at flexion extension view, CT, and surgical exploration and compared it. And these are the criteria. And these three criteria you should memorize because it will help you diagnose things that other surgeons will miss. Number one, make sure that you've got adequate flexion extension views by making sure that they moved at least 4 millimeters at a non-operated adjacent level that's not fused, because that tells you that they did a good enough flexion and extension view so that things move. Number two, maximally magnify the image. As I showed you previously, when you magnify that image, you can see that there's a gap between the cage and the rest of the bone. So if you maximally magnify it, you're much better able to pick out the exact same spots between flexion and extension to tell whether there's been a fusion or not. And number three, you must have less than a millimeter of interspinous process motion in order to say that there's a good probability that you are going to be fused. Now, that's not perfect because the specificity in our study was 96%. The positive predictive value was 97%. Sensitivity was only 86%, and the negative predictive value was only 83%. Now, if you use greater than 2 millimeters of interspinous process motion, which a lot of studies have used up to now, the sensitivity drops down to 47%, negative predictive value drops down to 57%. So you can't use less than or equal to 2 millimeters, otherwise you're going to get very inaccurate criteria. We also looked at CT criteria for a fusion and published this study also in Spine in 2013. And what we found was that you cannot look at what's happening inside the cage because this one looks like it's fused, this one looks like it's fused, and this one maybe not because there's a little cleft there. However, in these, there is no what we call extra cage or extra graft bridging bone. In other words, you have to have bone forming across outside of the cage or the graft. That tells you that there is new bone formation. And when you see this without any new bone formation outside the cage, because you can put things like biocoral, you can put allograft that just sits there and looks like it's fused with bridging bone when it isn't. And what we found was that all of these ended up not having a fusion. And going back to that doctor that was told that the two level had all fused, that's because the surgeon was looking at the graft inside the cage and they didn't look outside of the cage. They said, yeah, there's bridging bone there. It looks like there's some there and there, but there is no extra cage bridging bone. There's no bridging bone back here or here or here or here or here or here. And the patient had a clear pseudarthrosis. So we published this study on 262 patients and using the CT and surgically confirmed dynamic studies. So to reiterate, on the plane radiographs, you got to have greater than 4 millimeters at a non-operated level, greater than 150 or maximal magnification to make sure that you capture all the flexion extension changes that you see and you can pick out exactly the same point on both the flexion and the extension spinous process. And if it's less than 1 millimeter, it's most likely to be fused. And then for the CT, you must look at not what's going on inside the cage or inside the graft, but extra outside of the graft, outside of the cage, you must see bridging bone. And if you use those criteria, you will be able to diagnose a pseudarthrosis. And let me tell you something. About 90% of the spine surgeons out there don't know these criteria. They look at what's happening inside the cage. They just look at eyeball deflection extension views, or they use 2 millimeters, or they use something like 3 degrees of angular motion to detect the pseudarthrosis. And they're going to get it wrong. And they're going to tell their patients, there's nothing wrong with you. You're solidly fused. Your MRI shows that there's no compression there. I can't help you. And that's where the patient seeks out someone else. And if you learn these criteria and you can actually diagnose the problem, your patients are going to write about you on Google. They're going to say in the reviews, I went to 3 different doctors. None of them could make the diagnosis that I had a non-union until I went to this doctor. And that doctor, within 5 minutes, said, see how much it moves there? See the lines? See how many millimeters you move here? And they say, I can see that. I can see that there's a cleft outside of the cage. Why couldn't the other 3 doctors see that and figure that out? And in medicine, knowledge is power. The more you know, the more you can diagnose. The more you know, the more you can treat. The smarter you are about being able to read x-rays, the better a surgeon you will become because you will be able to diagnose things that no one else can. And when it comes to ACDFs, most surgeons think ACDFs fuse 100% of the time. In fact, in some surveys and so on, surgeons say, yeah, I get 100% fusion rate. I've never had a non-union. Well, I can tell you something. There's almost nothing that I have done that has 100% success rate. 100% success rate. It just doesn't happen if you do enough of them. In fact, when I looked at one-level ACDFs in the prospective randomized multi-center study comparing a one-level ACDF to a one-level artificial disc replacement, I found from these were some of the top surgeons in the United States that randomized these patients. It turned out that at 6 months, not 100% refused, not even 80, only 60% were healed at 6 months. At 1 year, only 80%. At 2 years, around 90%. It took 5 years to get to about 93% fusion. So all these surgeons who were saying, oh yeah, I got 100% fusion rate, that's only when they looked at it and didn't look very carefully. When other people looked at it, the fusion rate was much lower. And here's the other caveat. In this study, these were all looked at by radiologists looking at angular motion and greater than 2 millimeters of interspinous process motion. I just told you how inaccurate those are. So the actual fusion rate is actually much lower than this for a one-level ACDF. So in other words, non-unions at 6 months, they're rampant. At 1 year, it's probably closer to 60%. There are plenty of non-unions. So when a patient comes back and they say, my pain went away after the surgery, what it means is that after the surgery, if your pain goes away, that means they operated at the correct level and did a good job. And then it started coming back after a period of time, 3 months, 6 months, 9 months, 1 or 2 years. If it starts coming back and it's in the exact same distribution, let's say they had preoperatively numbness in these two fingers, it goes away and then it starts to come back. They have tingling, they have pain coming down the arm. Before you even get a study, your first impression, your history taking should lead you to the diagnosis that there is a high risk of this patient having a pseudoarthrosis at that level. That's the history part. You examine them and you say, it looks like you got a C7 radiculopathy again. You get the MRI. There's nothing wrong there. Even if you have no compression, it's the radiculitis, because when you have a pseudoarthrosis, your body thinks of it as something that's inflammatory. It sends out inflammatory chemicals. It irritates the nerves, and you get a radiculitis without compression. You fix that by completing the fusion, those symptoms will go away. Now, only about 50% of patients who have a pseudoarthrosis will become symptomatic. So not everybody needs a fix. A pseudoarthrosis is not dangerous, and you should wait at least 6 months to try to see if it'll go away, unless you have a profound neurologic deficit. And then I operate for a pseudoarthrosis when the patient says, I can't stand the symptoms, I want the surgery, because, as I said, it's not dangerous. Now, if you have somebody who has a pseudoarthrosis and the screw is backing out, you need to warn them that this is likely to keep backing out. And you still don't have to have surgery, but if they have any dysphagia, if they have a sore throat that won't go away, if they have any fevers or chills, you should tell them you need an x-ray right away, because things have been reported where this goes in and ruptures your esophagus. And there's even one case report of a patient who had a non-union, who had a plate with 4 screws in it, a one-level plate. And then the next x-ray shows the plate is gone, and the surgeon says, when did you have surgery to remove the plate? And the patient said, I never had surgery. And he goes, no, come on. The plate used to be there. It's not there anymore. The patient says, I never had surgery. And so they wrote it up as a case report where the entire plate and 4 screws extruded through the esophagus, went down the alimentary canal and out into the toilet. Patient never realized it. So that can happen. People can even pass a screw through the esophagus and not have it cause any problems. But there are also plenty of cases where it perforates the esophagus. Patient has a rip-roaring esophagitis, mediastinal infection, and a terrible course, and even death. So you need to make sure that when the screw is backing out like that, you keep a reasonable eye on the patient. Now, it can happen in a day, so you can't keep getting x-rays every day. So you have to warn the patient about the signs of esophageal perforation or esophageal infection. I love treating pseudoarthrosis because, number one, if the other doctors haven't been able to diagnose it, and I diagnose it, my patients who come to me and I say, you have a non-union, they thank me because they say, the other doctors couldn't figure this out. I'm so happy you were able to figure it out. I'm so happy because as soon as you fixed the non-union, all the pain went away. The results are actually, I think, better than treating a primary ACDF. So if you learn how to diagnose a pseudoarthrosis and you treat it well, those patients will be some of your most grateful and happy patients, because typically they've been going to doctor after doctor and they've been told there's nothing wrong with you. and then you figure it out. When you treat it anteriorly, again, you can treat a non-union. This happened to be a non-union. You can see the little grafts that the surgeon put in. On the lateral, it looks like everything is fused together and there's bridging bone, when in fact on the AP, you see the clefts here and see that they put in a tiny little graft. You can take it out, you can realign the patient and get much better alignment. And the one issue is that you're going back in anteriorly and you're not adding any more material. And so again, there are some disadvantages because you will not get 100% fusion rate. And you need to do more than what they did the first time in order to get a higher fusion rate. And if they put in a plate, you remove it and you got to put in a new plate, it's going to be harder to find the holes to get those plate screws in. So if you do, we did this study, if you at 1 year, if you go in back in anteriorly, you get about an 80.5% fusion rate. At 2 years, 92% fusion rate. If, on the other hand, you leave everything in the front alone, you just go in the back, you get 100% fusion rate by about 1 year post-op. Because now they're locked in the front, you lock them in the back. It hurts much more for the first few weeks, but you're operating in a virgin field. There's no dysphagia, no need for autograft. You can put allograft in there, and almost everybody fuses somewhere between 3 to 4 months, and certainly by 6 to 12 months, 100% will fuse. So when that patient comes back with recurrent symptoms, don't do what those surgeons did and bury your head in the sand. Nobody, not the patient, not you, the person who did the surgery, not the insurance company, no one wants to do that second operation. But if you can correctly diagnose those problems and then definitively cure that problem, then you will be the hero. Don't be the surgeon that says there's nothing wrong, because your patients aren't going to stay with you. And once they go to a surgeon who makes the diagnosis and treats it properly, they are going to tell on average 10 people how lousy you were, how dumb you were for not being able to make the diagnosis. And they will go around singing the praises of the surgeon who actually figures it out and then treats them and makes their symptoms go away. When you do that second operation, make sure that there's no number 3 or number 4. Do whatever it takes for the second operation, especially if you did the first operation and it didn't go well. Make sure that there's no number 3, because most patients will not stick with you for 3 tries if the first 2 did not work to cure the problem that they were looking for. And so after 2 failed operations, most patients will seek out another person. This is the review of an orthopedic surgeon who at this operation was told that there was nothing wrong. When I fixed her non-union, she says, I initially chose a local surgeon who I believed to be competent to do what I thought was a relatively simple single-level surgery. I had a very poor outcome. Initially, she did well. The symptoms came back. After being gaslit for months and being made to feel crazy, even as she's an orthopedic surgeon, it has literally changed my life, she said, when I fixed her and told her. And I showed her, look, there is motion between flexion extension view and there's no extra cage bridging bone. And when I fixed her, she was a very happy camper. And I have patient after patient. Almost every 1 to 2 months, I fix a patient like that. So I think it is very necessary for a surgeon, especially a young surgeon starting out, to be able to understand and be able to diagnose a pseudoarthrosis, because then you will be able to beat out the 90% of surgeons who've been in practice for a much longer period of time, who have much more experience than you, but are not as knowledgeable as you are at being able to diagnose a problem that is there in plain sight and being missed by those older surgeons. Thank you very much for that, for your kind attention. I'm happy to take any questions or comments about the talk.
Thank you very much. That was very interesting. And I think Jan is coming with the first question.
Yeah. Thank you very much, Dr. Riew. It was really insightful, your presentation. So how do you approach end plate preparation, infuse preparation, and screw positioning during ACDF procedures? And is there any specific procedures or steps that you take to optimize your fusion rates?
Yeah, so there are a number of things. Number one, for the end plate preparation, I try this. So you have the cranial end plate that is concave, and then you have the caudal end plate that's straighter. So I try not to burr all that subchondral bone down because you want to keep that most of that cortical bone intact. So when it's curved like that, what I do is I just shave off the anterior curve so that it's kind of straight here. Now, and then the bottom, it will curve. Let me see if I can, yeah, there we go. So it's curved like that. So the top I make straight, and then the bottom, I cut off the bottom so that again, that superior end plate is straight. And then the caudal end plate, you don't have to do as much work because once you remove that little curve and done, and the middle part where that bone is the most concave, you don't really have to take any bone there. You just take it from the front and you take it from the back, and that way you've got a very straight. On this, you generally don't have to take much bone at the caudal end plate. You just have to go out to the lateral edges to make them kind of flat. That's number one. By doing that, you keep most of the strength of the bone intact so there's not a lot of subsidence. Number two, you want to make sure that you cover as much of that disc space as possible with the biggest graft that you can find. And you want to cover it. So if you glue two pieces of wood together, do you think you get better results if you use a little tiny spot of glue or you slather the glue onto the entire piece of wood so that when you stick it together, the glue is everywhere? Well, of course, it's obvious. It's much better to slather the glue everywhere. And the analogy is that when you put in the graft, if you put a tiny little graft, it's only going to try to spot weld in that one spot. If you put the graft to fill as much of the space as possible, you will get better results. So if you're using cages, you want to use the biggest cage possible. If you're using autograft, you want to take the biggest autograft. If you're using allograft, you need to take the biggest allograft. I used to take fibula allograft. I don't anymore, but if you use fibula allograft, I used to put two and sometimes even three of them side by side to fill as much of the space as possible. Number three, when you put on, if you hang a television on the wall and it's an expensive TV that you don't want to drop from the wall, should you just take the same size screw to put into the wall, no matter how heavy the TV is? Should you just say, I'm just going to use the flimsiest little screw. I'm going to make it go in by about, 2 centimeters. Or do you say, the stud back there in the wall is about 6 centimeters deep. I'm going to try to put the screw to be 6 centimeters so that I use the longest possible screws and I use the biggest diameter screws possible. I use as many of them as I can because that way it makes it less likely that TV is going to fall off that wall if somebody leans against it or if you have a little earthquake. Well, obviously, that's an obvious carpentry answer. So when you put on an anterior cervical plate, you want to put in as long of a screw as possible. Ideally, I mean, even if it goes a little bit 1 millimeter into the canal, as long as you don't have congenital spinal stenosis. Even we used to use bicortical screws. Now, I'm not saying you should use bicortical screws, but we did a study that showed that if you have screws that go beyond, the longer the screw, the higher the fusion rate. Why? Because the longer the screw, the better the biomechanical fix, the less motion there is. And when there's less motion, it heals faster. If you take a broken bone and you put it together and you keep it absolutely still, then it can heal in as little as 6 weeks. If you move it every day, just a little bit, 40, 50, 60 times a day, then that bone may never heal and you'll develop a pseudoarthrosis because the body senses that there's supposed to be motion there and it starts putting in fibroblasts there to maintain the motion. Whereas if you keep it still, the body senses it's supposed to be bone, and what it does is it sends in osteoblasts and it heals like that over time. So whether you have a tibia fracture, a femur fracture, or a cervical fusion or a lumbar fusion, the more you decrease motion, the faster it heals. So that's why we use plates with the longest possible screws. Now, even if you use a plate with the longest possible screws, your head weighs about 8 kilograms. And if you multiply that by the distance from that 8 kilogram down to, let's say, C6-7, there's a long lever arm. Now, there are 3 studies that say that after you do a 1 or 2 level ACDF, you don't need to immobilize people in a collar. Every month, I see somebody who comes in who says, yeah, my doctor told me I didn't need to wear a collar, or I just needed to wear it for 2 weeks. And I look at the bone biology and say, how many times does bone heal in 2 weeks? And the answer is zero. 0% can heal in 2 weeks. And so wearing it for 2 weeks makes no sense. And wearing the collar, as you saw in those flexion extension views, even at 6 months, you see interspinous process motion. So that means that if you bend your neck up and down, you're going to see motion, even with the plates, even with those standalone cages with the screws going in and out, it moves, which means that it moves at 6 weeks, it moves at 2 weeks, it moves at 1 week, it moves until it is solidly fused. So do you think it's better to keep that stuff in there and also use external mobilization to remind the patient not to move the neck up or down, or to tell the patient, you can do whatever you want. I put a plate in there so you can move your neck as much as you want. You don't need an external immobilization. Well, that's also common sense. If it moves less, it heals faster. And that's why my patients heal very fast. And that's why I say to the patients, look, you're going to hate me for the first 6 weeks because this collar that you wear 24 hours a day, 7 days a week, except to take a shower. When you're working on a computer, you're holding your neck still, so you don't have to wear the collar. When you're watching television, you're holding your neck still. But all the other times, I want you to wear a collar because it will help you heal fast. And I don't mind if you hate me and curse me out every day for 6 weeks, as long as you like me at 6 months and you're happy at 6 months, because it's the long-term follow-up that determines whether you think I'm a good surgeon or not. And so you and I have to work together. I can do the best job of doing the surgery, but unless you take care of it, it's not going to heal. So those are some of the things that I do. External immobilization to make sure that you're healed. Good end plate preparation. You want to put the biggest graft possible, and you want to use the longest, the most stout fixation possible to diminish motion there, because that's the whole reason why we use plates, is to try to decrease motion at the fusion level. So if you're not trying to do that, there's no point in doing the plate.
Yeah, that's very, very good key insights. Thank you so much. It's really reliable and we can think about it. Jumping on the second aspect you said about the cage size or the graft size, how do you orientate yourself? Like, do you look at the adjacent levels, or are you scared of overstuffing? Like, do you think there might be a negative effect of this? Could you share something?
Yeah, so in terms of the graft height, you want to get something that's snug. You don't really want to overstuff, because if you overstuff, you're going to hyperlordose the patient. And when you do that, you narrow down the foramen. Now, you can do that. Let's say you've got somebody with kyphosis and you want to put in a bigger lordotic graft. It's okay to do that as long as the foramen does not hyperlordose and cause foraminal stenosis. Now, here's what happens. You have the facet joint that are well aligned like that. If you distract like this, you don't cause foraminal stenosis. But if you lordose the patient, the superior articular facet at the caudal level goes like that. The inferior articular facet at the cranial level goes like that. And if my face is the nerve root and you do this, now you're impinging on that nerve root. So you don't want to do that. And if you do that, you got to make sure that you give plenty of room anteriorly where the uncinate is to do a thorough decompression so that nerve root has enough room. So that's a problem that I've run into a number of occasions, where I take a kyphotic patient and I hyperlordose them, and then postoperatively they wake up with a nerve root deficit because this thing is impinging on that nerve root, and you end up with a root palsy. So you got to be very careful how much you overstuff. But if you want to correct the lordosis, I mean, you want to create lordosis in a previously kyphotic patient, you do have to do that to a certain extent. And the best way to do that is make sure that the foramen is wide open. If the frame is already wide open, it has enough room that you can do that without it impinging on the nerve root, and you'll be able to create lordosis. Um, and as far as sizing the screws and the graft and so on, what you can do is you can I size the disc space by putting in a known, let's say a 16 millimeter screw after I've done the ACDF and everything is cleaned out. I just put it inside the disc space and I say, okay, that screw is going to fit very nicely from back to front and it's going to be like that. So then I put it in partially. You get a spot fluoro X-ray and you say, okay, that's going to be perfect. I screw it in all the way and lock it down. And that way I know I can get the longest possible screw. But you measure it by just putting it inside the disk space. Same thing with the depth of the graft. You just using that screw, you say, okay, it's going to be 16 millimeters from front to back. You can also measure preoperatively on the CT and MRI, but it's not quite accurate because there is some magnification error. But by putting that screw and using it as a measurement device, now you say it's 16 millimeters from anterior to posterior. I'm going to take a graft that is 16 millimeters deep, and then width, you see directly what the width is going to be like.
Exactly.
Great.
Very thanks. Very good
Yeah.
advice. Thank you.
So
Yeah,
I don't know, Yana, how do you think about the time? We have another question. Do you have time for that?
yeah,
Sure.
I think so. It's a very good
Yeah,
discussion.
sure.
So we want to
So,
grab all the insights we can
yeah,
get.
for sure.
Thank you.
I think one question we already talked about was the eventual conservative management in some cases of pseudoarthrosis. But the next question would be what the role of SPECT-CT might have in assessing spinal fusion after ACDFs.
Yeah. So I get a SPECT CT very infrequently because I can tell on an MRI. When you look at the MRI, if you see a black line where the old disc space was, that means it's a pseudoarthrosis. If it's fused, you'll see gray on a T2-weighted image. You'll see bone like gray going right across the disc space, number one. Then I look at the flexion extension, I look at the CT. If for some reason I look at all of those and I'm still not sure, that's when I get a SPECT CT. And so I get it less than 1% of the cases because most of the time I typically will get it. The most common reason I get it is somebody has a titanium cage in there, and I can't tell. The titanium cage starts where the bone starts growing into the titanium cage, but it just doesn't, there's a cleft there and it just never grows fully. So there's micro motion there, but there's not enough motion to create, there's not enough motion for you to see it on flexion extension views. You can't see what's going on inside the cage because it's like a trabecular bone, kind of a cage, and you can't see what's going on. But the patient still has enough motion that it causes inflammation and they have pain. So in a case like that, I get a SPECT CT and that will show that it lights up in that area. And then I know that it's a pseudoarthrosis.
Okay, nice.
Maybe one last question. I mean, we have so many more, but also according to that, I mean, there are lately papers who also telling about machine learning based strain based fusion criteria or measurements. Do you think this is the future of fusion research, or do you think we're really good already?
No, absolutely, it's the future. So when we did a study in AO, looking at how good surgeons are at detecting non-unions on flexion extension views, whether you're talking about plumbers, electricians, spine surgeons, no matter what field you are, there are people who are good at what they do and people who are lousy. Some people looked at 3 millimeters of interspinous process motion and said that there was less than 1 millimeter. When they picked out their spinous process points, some picked this one for the flexion and this one for the extension. They were terrible. About 50% of the people who look at interspinous process motion pick out the wrong spots and can't figure it out. It's the same reason why some people you see their ACDF and you go, wow, that looks like a kid with a crayon did that operation. So most surgeons, or at least 50% of surgeons, are incapable of picking out the exact same spots. Radiologists are even worse. When I taught these criteria to the radiologists, they would call fusions and I would sit there and go, oh man, I see where they picked the spots. It's not in the same spot on the flexion extension. So many surgeons can't figure this out. On the other hand, there are programs, and those programs are reasonably good as long as you get good X-rays, and they already exist. And we're trying to incorporate this in AO to do our study on how good interspinous process motion is. That is definitely the wave of the future. In 20 years, you're not going to need radiologists because that's pattern recognition. And radiologists, there's not a day that goes by. In 95% of the cases, when I look at an MRI or a CT, I say the radiologist missed this. When I look at what the spine surgeons have read, I say in 95% of the cases, the spine surgeon didn't see this, didn't see that. In order to be a good spine surgeon, you have to be a phenomenal neuroradiologist. And if you don't see something that a neuroradiologist has missed in 95% of MRIs, then either you have the most phenomenal neuroradiologists in the world, or you don't know how to read MRIs and CAT scans and need to learn how to read those. Because if you think that the neuroradiologists know how to read them, which I used to for the first 10 years of my practice, I thought they were much better than I was. But because that's all I do is read cervical MRIs and CAT scans, I have read many more than just about any neuroradiologist out there, and I'm able to pick up things that they have not been able to pick up. And I know how much they miss things. They overcall, they undercall. They miss the foraminal view, they don't do this. And so it's important for you to learn how to look at your own studies.
Very good. It's
Thank
probably
you.
also
Thank you
helpful
very much.
to the surgeon and know how it looks inside and what you have to look for. But
Right.
that's absolutely a good point. Yeah, I think Jan, if you agree, I mean, for the sake of your valuable time, Dr. Riew, that was very, very insightful. We're super grateful. Thank you for your time. And yeah, Jan will give some closing notes.
Yeah. Thank you, Dr. Riew. Thank you, Jana. And we're deeply grateful for our all members for taking their time to join us in this academic talk. Stay tuned for the next episode where we'll continue to explore the AO Spine Knowledge Forums and the future of spine surgery together. Thank you.
Thank you very much for having me. And I forgot to say, I go by Dan to everybody. So please don't call me Dr. Riew, just say Dan.
Okay, then.
All right. Very good. Have a great day.
Bye.
Great day.
Bye.
Thank you so much. Bye.